So to start with, we're going to find the structures that we need to be looking at. So that's our first part with our F. So finding, of course, we've got the thyroid there nice and midline, nicely centred. We can see the common carotid arteries pulsating there beautifully. Laterally, we've got our marker end here, which is conventional towards me as the sonographer, and this indicates the right-hand side of the patient, and this is going to be the left-hand side. So here we have the left lobe, the left CCA, the right lobe, the right CCA. We have the isthmus, which is that band of parenchyma or thyroid tissue that joins, it's like a little bridge that joins the right and the left lobe. Here we have the tracheal rings, so we can't see anything in there because of the gas interface. And then here we have the esophagus, always going to be on the left-hand side. Make sure that you don't mistake that for pathology. You can see it's quite hypoechoic, and it always is going to sit tucked in close to that tracheal region there. We've also then got our strap muscles up here. So you can see the demarcation here between the sternohyoid and the sternothyroid. And then lateral to that, just over here, we've got the sternocleidomastoid muscles, and they're bilateral over here. We should also see the jugular, internal jugular veins pulsating. They're bilateral as well, and they're going to be lateral to the artery. Now that's how we also know that our pressure is correct. If I'm pushing too hard, I can actually depress that jugular, and that's certainly not what we want to do. So I want to see round jugulars to match the round arteries as you are scanning. So just watch that pressure. Coming down posteriorly as well, we've got from our esophagus, we've got our bony landmarks, our bony structures. If I come down a little bit further, this is all blackout because this is down into the neck cartilage. So we don't want to set our depth too deep. So you want to make sure you're just seeing the bony landmarks there, and your longest colloid muscles are going to be in that posterior section. So we know we've got our landmarks. We can confirm all of those landmarks are correct and that it's fitting on the screen. If you do have a thyroid that's a little bit larger, you might need to use wide scan. However, in this instance, we're not going to. We try not to do that because it does degrade the image. So let's do the O for optimizing. We're going to do depth, which is fine. Focus a little bit up there, keeping in mind that we need that posterior section for resolution, and TGC, we want it a little bit darker there in that anterior aspect. Now you're going to get reverb because look how superficial that isthmus bridge is. It's tiny, there's hardly any subcutaneous fat, and we've got the skin line here as a really nice thin layer. So you're going to get reverb. Don't be too concerned about that isthmus and having the reverb. Then we've got this space here, which is the cartilage, which is going to be anechoic space, and the tissue of the isthmus just drapes over anterior to that cartilage there. So we've got all of our landmarks. We know we've got our strap muscles here, and we're in a place to start doing our survey. So from here, we're going to survey the entire gland. Now to start with, we're going up to the head, to the submental region, coming back to midline, looking at the contours, trying to keep them centered, all the way down to the feet, making sure that this is the lower section, the lower pole. You're going all the way out till it totally disappears, so that I know, and 2 centimeters underneath to make sure there's no lesions or any adenomas that might be sitting there, and then back to midline. So this is just a general lie of the land, general overview of what we're likely to expect and how we can plan the scan. If I've got loads and loads and loads of nodules going on, I know I've got to take a bit more time because I'm going to have to take nodule images in 2 planes with 3 measurements. If I can see everything's perfectly fine, it's going to be a slightly quicker scan, so I might take a bit more time doing some vascular studies. So please make sure you're really planning ahead for your scanning. So second sweep, back to midline, all the way through. This time I'm looking at the content, coming all the way up into that submental region. I say it's a little bit like a church steeple. Coming back, trying to keep it all on the screen. And it's just a general overview. Then I'm going to come across to the right-hand side, just readjusting my grip. My patient's going to look away, all the way up, trying to keep that carotid in the same place, all the way out and back. I'm just going to fix my depth for contour. Now content all the way up to the head and back to midline. Then we stop. Really make it clear that this is what you're doing. I've seen some students who are still coming to fan down and then they start sliding at the same time. I want you to make sure that you finish at midline, go to the other side, we're at midline, reset, depth focus TGC, I'm going towards the head, all the way out, keeping that CCA basically in that same vertical line, all the way through. There's a little tiny little adenoma down there, all the way through, back to midline. So now I've thoroughly checked that as an overview. So it's different from a dedicated study on each lobe. So what we're going to do is take an image, just going to readjust, center those CCAs, and that's going to be thyroid trans. Then we're going to put a little bit of colour on there. Now we want to make sure we've got at least half of the CCAs on there and the isthmus. So we can see here we've got half the CCAs. That's just telling us that the machine is actually working, that if a thyroid is hypovascular and has no vascularity, we're still going to see colour in those carotids. So all you're going to do is just fan through a tiny bit. It's not a full survey. We don't do full surveys in colour. It's just to see the general look of the gland in terms of vascularity. We're going to increase the colour until we get that crazy colour mottling there. Don't just reef it up really, really quickly. Just gradually increase that so that you can reduce it until there are no echoes left inside the trachea. So I'm still getting some, and I'm getting nice vascularity of the gland. So here we've got vascularity here, we've got our CCAs showing vascularity, and that would be nice normal vascularity for that gland. So we take that image. Now we're not doing a survey in long. I know some of you would probably ask, Shani, don't we always do trans and long? This is just an overview, a general overview of the structures of the neck. Now we're going to do a more dedicated study. So we're going to have a look at the isthmus. What we need to do is zoom. Now don't over zoom. We want that zoom box around about 1/2 to 2/3 of the size. HD zoom, depth, focus needs to be anterior and TGC. So I'm scanning through, fanning down to the feet, looking at that isthmus bridge all the way through until it disappears, looking at the contour, that it's nice and smooth, and now looking at the content. Also planning where I'm going to do my isthmus measurement and back through. So I'm happy with that. I want to get a nice measurement where I can see the anechoic line of the cartilage and the parenchyma of the isthmus. So I'm going to take that there using my calipers in AP. Don't include the hypoechoic or the anechoic space. That's going to be my isthmus. Then I'm going to go onto my side. Now you will choose this side by flicking a coin off and choosing left or right on your test. So I'm going to go to the left side. So I'll get my patient to look towards me. I'm going to reorient my probe and make sure that I've got the trachea on the screen. The carotid needs to be around about 2/3 of the level across, so that this is the main area that I'm looking at, and that needs to be what is centered on the screen. So again, I'm going to go superior until it disappears, looking at the contour. There's that little adenoma there. I'm just pointing it out for you, little cyst. Down in the inferior pole, all the way through, back to midline. So that's my contour, coming up to the head, all the way out of the gland. Nice smooth surveys, and that's my content. Now I'm going to be turning in longitudinal, so get the largest part or the thickest part of that lobe, and then I'm just going to turn into longitudinal, keeping that on the screen. Now the way I explain in longitudinal, we're going to rotate to elongate, and you can see I'm fanning to find to make sure that I get all of that lobe on the screen. So to make sure that I've got all of that lobe, I call it a little bit like a duck's tail, and I'm going to do a trace to show you what I mean when I can, if you can see that area there, that is what I call my duck's tail, and I'll show you here. They're outlining the outer edges of that gland. So this is to the head, this is the superior portion, so superior anterior portion, superior posterior portion. This is the inferior portion towards the feet. So they are showing you where the edges are. Students do find it a little bit tricky to actually see where the thyroid starts and finishes. So hopefully that helps you with my little ducktail analogy. So it comes out, it looks a bit like a ducktail here, and then you've got it where it pinches. You can see it's slightly anechoic space there. That's where it comes to. Don't be measuring out here, which is where a few students get into some trouble. So make sure that you're coming down and checking that you have the entire gland on the screen. Again, if you need wide scan, you can use wide scan. I'm not going to need to in this particular survey. So going into longitudinal, I'm going to fan laterally, so out towards the patient's shoulder. There is my common carotid in longitudinal and horizontal. Remember, if your CCA looks like that, that means that you're not going to have your thyroid lobe nice and horizontal. And remember, with your physics, anything that's horizontal is going to be parallel to the beam and giving us a really nice image. So here we are, all the way out to the CCA. We don't need to go any further to the jugular. Coming back through medially, through the rings of the trachea, we can see here, which shows us the isthmus. So that's our contour. Then let's have a look at our content. All the way laterally, coming back in medially. There's those rings. So now I feel like I've assessed that gland thoroughly. I'm coming back into transverse. I'm going to go all the way out of the gland superiorly towards the head, and then just come back a little tiny bit to show that upper pole. So that's going to be left lobe trans upper. Students often ask, where do you need to survey, or where do you need to show that image? Midline is here where you can see the isthmus bridge, so it just has to be superior to that midline. So I go all the way out and just come back a little bit so I know that that is in the upper pole. Just checking, I can't reduce my depth anymore. 2.5 is as shallow as I can go. So this is going to be my midline. Focus up a little bit, TGC. Holding that. Remember, your CCA that's here is going to be pulsatile, so you'll need to use that cine loop so that you can try and get it at diastole. Here's our caliper measurement for our mid.
This is where then you put your colour Doppler on. You've already set the colour, so you don't need to do that again. Just show that half of the CCA is showing colour and that it is of normal colour throughout the gland, and take that as your mid, and then go on to doing the inferior pole.
And then coming down all the way out, I know I'm out of the gland, so this is going to be inferior. You need to have enough parenchyma that your radiologist actually knows that it's a thyroid and that it looks like a thyroid. So I'm just getting that where it's at systole, and that's going to be lower. Going into longitudinal, getting that ducktail, beautiful. That's going to be left long. Here's our calipers from the ducktail to the other, keeping them horizontal. And this is a nice thin thyroid, anterior to posterior. So So coming out laterally, so that's as far as I need to go. I'm just going to come back a little bit, just angle around. That's going to be my lateral image. You're not always going to get the CCA in that lateral image. Some thyroids you can actually see the thyroid over the top of the CCA, but not all, so don't worry about trying to get all of that. Then medially, there's those tracheal rings. So I'm just going to come back a little bit from the tracheal rings, elongate so that it looks like a thyroid and that it doesn't look like there's any pathology. Be aware of shadowing when you're doing that medial so that you've got an entire gland. And that's that thyroid. Then we're going to have a look at the cervical chain. Often I get asked, where are we looking for this? What you need to do is, if you're doing the left lobe, your CCA moves to the left-hand side of your screen. So just think left is left, right is right. So keep that CCA on the left of the screen. We've already interrogated this side, haven't we? So what we're looking at is anything that is lateral to the CCAs as far around posteriorly as we can possibly see. So keeping that on the screen, I'm at midline at the moment because you can see thyroid. I'm going to travel superiorly. I'd like a little bit more depth focus and TGC because I do need to be able to see posteriorly down past the vertebral processes. So you need to give yourself just a little bit more depth. So keeping the CCA in the image, we're going all the way up. Now the CCA disappears. Coming across, you can see a few nodes there. Here's a little node, I'm just going to point it out for you. There's a node there. We can see the echogenic hilum inside here. Okay, there is our submandibular gland here. So that's when you know you're as far superior as you need to be. Coming back down, picking up that carotid, coming around more lateral. You can see the little nodes popping in and out. So this is what we're looking for to start with. Coming all the way down towards the feet, angling underneath the clavicle, and there is our landmark here, which is a subclavian artery, and that's as far down as you need to go. So that was my first sweep, looking at the contours. Now I'm looking at content, so I'm going to just confirm did you see that node there, popping in and out all the way? There's another node there, a couple of nodes. So that's the purpose of this scan, is to make sure that those nodes are less than 1 centimetre or 10 millimetres, which that is, it's 0.4 in the AP, so that's fine. All the way up, let's get to that submandibular gland now. I'm going down to the feet, down to that subclavian. I've interrogated that thoroughly. So I'm going to take an upper image again, up to the submandibular. So it's going to be left cervical chain upper. And then there's that thyroid coming in down to the lower. Bit of cine loop. And that's your thyroid scan.